Good afternoon and welcome to today's presentation, High Quality Outcomes, the link between your performance and PTN performance. My name is Valencia Harper and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our Health Visions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. Today we are privileged to have Cindy Eiseman as our presenter. Cindy Eiseman is the project manager for Health Visions Delmarva, a practice transformation network working through the CMS Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to perform improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality and Operations Director with Health South, Kindred, and several community hospitals. Cindy is a native of Pittsburgh and graduate of the University of Pittsburgh and the Troy University in Alabama. Cindy, we welcome your start.
Well, thank you, Valencia. I welcome everybody who's joining us today. We have an important topic to talk about today, which is how we're doing as a PTN and how each of our member practices is helping to support us. It's kind of a trade-off. We talk about the fact that the services we provide are free of charge, but I guess there's a catch to that. And the catch is what we expect in return is not only your participation with us, but also your data, because we aggregate that data and we turn it in, and it really shows how the performance of our total group is doing. So today we wanted to take some time to look at what the core measures are of the PTN, how you all are contributing to it, and what more, if anything, you can do to help support that goal for us. So these are questions to run on. We want to know what the goals of Health Visions Delmarva PTN are for the TCPI grant, how we're performing as a PTN group on those goals, how each individual in practice is impacting the PTN's performance, and then what can each of us do to contribute fully to the positive results of the PTN. Our first slide is really just an overview slide of what we call aim number one. And aim number one is basically enrollment. The aim is supporting practice transformation through clinicians and practices. And you can see in the first graph that our enrolled clinicians are currently above the 1600 level, a bit above, and those are active enrolled clinicians. We have a number of practices that actually graduated the first of this year, joining an MSSP-ACO and therefore not eligible anymore for PTN assistance, but moving forward in that payment model. So since our target was 1600, we are above our current target of 1600 clinicians. The next table shows how we are distributed as far as specialty distribution goes. And this is really effective as of today, or January 1st. The largest group of physicians that we have is actually the hospitalist group. Just today, we are completing assessments on a very large hospitalist group in Maryland, and so that's the largest number of individual specialist types that we have, followed closely by emergency physicians. So you can see we have a lot of inpatient-based clinicians. But we also have a good number of orthopods, pediatricians, anesthesiologists, OBGYN, gastro, urology, ENT, and radiology physicians. The final graph on the page is our phase distribution. So TCPI has 5 phases that each of you are working through as we go through your assessment every 6 months. We talk about what phase you happen to be in. The 5 phases are first setting aims, and it's a pretty easy phase. We all get out of that phase once we establish what our goals and metrics are going to be that we're going to measure, and we create a plan that has our mission and vision statement in it. Phase 2 is the collecting data phase. Right now, 23.35% of our practices are in that phase. Most of those practices either joined us late in 2016 or during 2017. And what they're working on right now is making sure they can accurately and adequately collect data and use it to help to drive their performance. Phase 3 is making improvement, and we have 21.7% of our practices in Phase 3. Phase 3 is about using that data that we're now accurately collecting to make changes within our practice to improve our patients' outcomes and our patients' experience. Phase 4 is reaching benchmark, and currently 3.3% of our practices are in Phase 4. That means that you're fully reaching benchmark. You have good MIPS measures, good other measures of performance that you might be internally tracking, and you're working towards completion of all the items on the TCPI assessment. And finally, Phase 5, where we actually have 1.3% of our practices right now. Phase 5 means that we believe, and your numbers would show, that you're thriving and you're ready for an alternative payment model. Now, there may not be an alternative payment model there for you, and so you may not be able to move into one right away. However, we know that from a quality, an outcome, a patient-family engagement, and a teamwork perspective, you would be ready to thrive in an APM environment. And then finally, our largest number is 45%, and that's our graduated to ACO practices. We have a couple of large groups that moved into the ACO environment as of January 1st after completing 2 years working with the PTN. And so we'll keep in touch with them and see how they're doing, but at this point, we are unable to continue working with them. And so we're going to be watching them from afar and cheering them on as they progress in this journey. If we look overall at the 5 aims that we're held accountable for, this is a summary statement for each one. We just talked about aim 1, where we're at 150% of our target enrollment. On aim 2, which has to do with health outcomes, we have 65 practices who are caring for about 130,000 patients who have diabetes, hypertension, obesity, or LVSD that have shown improvement over the past 2 years. In fact, we can demonstrate improvement in about 7,309 cases, and we've achieved 34% of our overall quality target with these measures. Aim 3 is about reducing unnecessary hospitalization. Right now, we can quantify information on 79 practices who are caring for 2.2 million patients. They've reduced readmissions by 151, and we've met 37% of our target. We look to increase this cohort in 2018 by the addition of another large primary practice and several hospitalist groups, as well as the addition of data from our Delaware practices, which we don't yet have. Aim 5 is reducing unnecessary testing. We have only 9 practices who are working on this measure right now. 2 of them are ED practices and 2 of them are radiology practices, and the other 5 are just individual practices, and we'll take a look at the kinds of things they're doing. They've reduced the utilization of the targeted services they're working on by 443 patients, and that meets 76% of our 4-year target. And finally, aim 4. This is the cost target, and really all these other targets lead up to aim 4. It's our way of quantifying in dollars what kind of impact our PTN is having on the healthcare community that we serve. Right now, 202 of our 364 practices have contributed a total of $5.7 million in savings to date. This could be Medicare, it could be other payers, and it's an estimated amount, but it ties directly to the efforts that we're doing in reducing hospitalizations, unnecessary testing, and improving healthcare quality. At this point, we've met 38% of our $15 million commitment on this particular aim. So to look at the depth and breadth, so how far is this reaching within our PTN, I offer you a few statistics. We have selected outcome measures that are applicable to 13 to 78% of our enrolled practices, depending on the measure. It's really hard in a largely specialist PTN to pick measures that a lot of people can contribute to. So we had to settle on ones that we could get the most data from and that the most practices were using. As far as looking at how many PTNs are contributing on each aim, 65 of our practices are contributing data on health outcomes, 46% on hospital admissions, 14% on testing and procedures, and 42% on cost savings. And the contribution rates on any individual measure ranges from 1% to 100%. It just depends on the measure. Again, our 4-year cost commitment on TCPI is $15 million, and we can demonstrate that savings both with our quality improvements and our reduction in any unnecessary utilization. So it's time for our first polling question. So Valencia, if you would like to launch that and then give me results, that'd be great.
Certainly. It reads, in looking at my MIPS quality measures for 2017, A, we made great gains and or scored well compared to benchmark. B, we made some gains and or want to improve further to reach the highest decile. And C, we monitor our data but need to improve our scores. So we're currently collecting those responses. We have about 30% that's voted thus far. We'll wait till we have about 75% fully participating. We're at about 54%.
Okay, guys, keep them coming in.
Okay, Cindy, it looks like we're at about 60%.
Okay. Why don't you go ahead, Valencia, and give me the results.
Okay, we have 50% that say we've made great gains and are scored well compared to benchmark. 22% we made some gains and want to reach the highest decile. And 33% we monitor our data but need to improve our scores. And that's 69% participated in this poll.
Okay, thank you. All right, well, I'm really happy to see that half of the people on the line made really good gains and are hitting benchmark, because that's exactly where we want to be in this first year. Some gains is also still good. And for those of you who are working on improvement, we definitely plan and will continue to stay engaged with you to help you find the ways to do that. The good news about those answers is one of the extra bonus opportunity points in 2018, so not in the data that you're submitting for MIPS for 2017, but for next year, is improvement points. So you can actually get bonus points for improving a score from one year to the next. So if you're not at benchmark already, it's not always lost. As long as you have a good MIPS score this year, you can even have a better one next year with improvement points. So I'm going to move on and talk a little bit about each of the measures that we collect data on, what they're showing us, and what we're hoping to see with these measures. And the first one is diabetes. And the measure that we use for diabetes is hemoglobin A1C poor control. So it's an inverse measure, and I want everybody to keep that in mind. What we want is for this line, the trend line, to be going down, and it is. So that's a good thing for us. We have a good positive trend on this measure. Right now, 80 clinicians across 25 practices who care for almost 9,000 diabetic patients are providing us with data on this measure. We're using NQFO 59 for everybody's reference, and our overall trend is improving. One thing that we can point out on this is a measure that we can actually quantify dollar savings on. So all the improvements that we make in this measure, we can estimate savings of $817 annually for every patient whose A1C runs below 9. So as we improve our performance rate and increase the number of patients whose A1C is in control, we add $817 for every one of those patients to our savings to the system. If we look at who seems to be doing particularly well on this measure within our PTN, this is a graph that shows that. You can see that our PTN average is 18.19%. Remember, a lower score is better. We actually have one practice, Podiatry Associates, who 100% of their patients are in control based on their monitoring and data collection. That's a podiatry practice, and so I think some of you, especially your PCPs, might look at it and go, yeah, but they don't have as many people that they're tracking, and that could be true. But I would like to call your attention to the rest of the practices also. Shoreview Medical is a primary care practice. We have a cardiology practice, a pulmonary, an ophthalmology practice, and a large FQHC. These are all still practices that are putting in place actions and initiatives that are helping to move their numbers down. And even these that are a little bit higher than our average, they have made consistent progress over the year in reducing the number of patients in poor control. Some of the key interventions are listed on the right-hand side. These are things that we have worked with practices on that we know will help to produce positive results on this measure. The first one, and it's always the first one on probably every slide we'll look at, is improved EHR use and data collection. You have to be collecting your data correctly. You have to understand how your EHR captures the measure and how it reports the measure, and ensure you're filling in all of the right fields in your EHR to be able to collect this accurately. The second thing is the use of PFE, or patient and family engagement, and you're going to see that on a lot of measures too. Patient and family engagement is really key to getting good results with these outcome measures. If our patients aren't engaged, if they aren't taking control of their own health outside of the doctor's visits, those doctor's visits aren't really going to help all that much. So things like patient logs, self-monitoring, education classes, touch-base calls with care managers or other members of the staff who can check in with patients are really important for our high-risk and emerging risk patients, which takes us to number 3, risk stratification and care coordination for high-risk and emerging risk patients. Granted, not every practice is large enough to have a care manager or a care coordinator, but almost every practice has some support staff that would be able, if we can identify who our highest risk patients are, to be able to be in contact with those patients with reminders, with touch-base calls, with teaching them how to use things like patient logs and self-monitoring equipment, so that they are really getting engaged and understanding that we're going to be holding them accountable for their care the way that they're holding us accountable for providing them with good care. The next item is team-based care, having the entire care team engage the patient and family in discussion of their plan and follow through. I've taught some classes where we talk about the fact that patients only remember 20% of what we tell them in an office visit. They forget 80% of it. One of the ways that we can work against those odds is to have multiple team members engage patients and families in conversation about what that care plan is. Repeat, repeat, repeat. Use teach back in order to ensure that you understand what they understand and that you can reinforce things that they aren't really grasping. In Delaware, the State Model Initiative offers great tools on diabetes management. And some of our practices who have pretty good rates here use the tools of the the Delaware State Model Initiative. Below here is the link to that initiative. There's actually information you can download and tools you can download, policy, procedure, best practice, that might help you if this is a measure that you would like to see yourself do better on. And then the use of standard protocols for high and emerging risk patients. So the use of daily huddles to flag patients who need that extra. You know, are you huddling before your office visits start for the day? Are you doing pre-visit prep to make sure you're identifying the patients whose labs you already know are out of whack, so that you know that you need to be talking with them about the subject when they come in and it doesn't get missed. So those are all key interventions that help us to produce strong results on this particular measure. The next measure, that's one of our core measures, is the hypertension measure. And the measure we use for that is blood pressure in control. It's NQF-018, if you want to look it up. We have 104 clinicians across 72 practices who are caring for about 26,000 hypertensive patients on this measure. And again, our overall trend is improving quarter over quarter. This is another measure that we can estimate cost savings on, and we estimate $420 in annual savings for every patient whose blood pressure is maintained in control. So when we add patients to the in control bucket, we can take credit for saving dollars. Another graph showing us how we're performing on this measure. Now, this is a regular measure where we want to be higher rather than lower. The PTN average is 67, and all of the practices that we put up on this one are actually above the PTN average. They also have made improvements, but more importantly, their performance is consistently above that average. Again, key interventions. Always start with improved EHR use and data collection. Make sure you're collecting your data accurately. Ensure the calibration of your office blood pressure cuffs and your patient's home devices for your hypertension patients. That should be a service that you offer routinely to them, to bring in their device and make sure that it is calibrated in a way that it's matching what you're able to do in the office, and that they're getting an accurate reading if you have them keeping a log at home. Again, the use of PFE, patient activation and engagement, logs, more frequent check-ins, the same kind of things that we do with our diabetes patients, we can do with these hypertension patients. It's important. Clearly, you're not going to have enough time to talk with every hypertension patient every week, but you can risk stratify your patients. You can look at your patients and run a report on the ones that have the highest blood pressure, the most erratic. You can pick the metric that you want to look at. and identify a list of the people who are having the most trouble keeping that blood pressure in control. And those are the people that you want to make sure they're doing a log and make sure you're checking in with them frequently. There is more information about blood pressure, hypertension management in our Care Coordination Toolkit. We created that in conjunction with the Bay Health Physician Alliance, and if you don't have a copy of it, please talk to your practice advisor. We can get you a copy, an electronic version copy of the Care Coordination Toolkit. It has a lot of great information, education, and patient use tools in there to help patients take control of their hypertension. Team-based care, just again like diabetes, having the entire care team engage with the patient, family, in discussion. The more they hear it, the more it's going to sink in and the more reinforcement they'll get. Delaware State Model Initiative also has information on hypertension, and participation in the Million Hearts program, which is a national initiative but is also running in all of our states, can be a real helpful thing. They have great tools, they have great processes in place that can help you help your hypertensive patients get in control. Okay, the next measure is BMI, and this one is about screening patients for BMI and putting an action plan in place for patients who need to address their weight. So 159 clinicians across 49 practices are caring for 71,000 patients who this could apply to. We do see an overall improving trend. It's not as strong as the other trends, but we do see an overall improving trend on this particular measure. It is not a measure that we have a dollar sign to assign to, but that's okay. It's still a really important measure because the performance on this measure impacts so many other health outcomes for our patients. And so we know it's a really important one to be working on in all of our practices. The average for the PTN performance is 50.83%. All of the practices you see here are operating well above that average, and one at even 100%, the Vein Center in Eden Hill. So what are some of the key interventions to produce results on this particular measure? Utilizing existing community resources and support groups. There are support groups out there for this population. You need to get an inventory of those, understand what they are, and refer patients to those groups. Or you could form your own, which some of our practices have done. Because they had such a large population to deal with, they formed their own support groups that meet semi-routinely with help and facilitation from the office staff. Patient engagement. Use the portal for easy tracking of progress by patients. We don't think about using our portals all the time as ways for patients to give us information, more as a way for them to get information from us. But this is a really good way to get people interested in using your portal, is to give them a tool that they can use that will help them to monitor their progress on their weight. You could use it for hypertension and diabetes also. Use a population health tool or application in conjunction with your EHR to flag these patients when they're due for screening. All of these measures that have to do with screening really rely on the fact that you're going to keep up to date when people need their screen done, if that's annually or biannually, however frequently it needs to be. Population health tools and some EHRs will allow you to program in those reminders so that they remind you and maybe even send reminders out to your patients when they're due for a certain screen. You can use a daily report to flag patients due for assessment as a fail-safe. So if you can get your schedule to include those flags and you do a daily huddle before you start your schedule for the day, you can identify for the whole team which patients are due for which assessments. And that can work as a fail-safe so that you make sure you catch everybody when they're due. And again, team-based care. This is definitely one of those measures that team-based care and that communication from different members of the team can be helpful for. You know, one of the things that we see with patients consistently is they're not always real keen to talk with their provider, their clinician, their doctor, their nurse practitioner about what's happening, especially if they maybe haven't been following their diet plan, following their exercise plan, following whatever care plan you establish for them. But sometimes they feel more comfortable talking to someone they see as a peer. So maybe your medical assistant or your med tech can ask some of those questions and engage the patient in conversation and encouragement. Depression screening. This is one we hope that we can get more practices to participate in because we think that it's a really important aspect of patient care that if it's not addressed, it kind of silently runs underground, right? And people maybe aren't doing as well with their medical, clinical conditions, And we don't really understand why, and we, identify at some point later that it's because they're either having depression or anxiety, or things just aren't going as well for them as they have been, and so it's bringing them down. On depression screening, we use NQF 418. We have 52 clinicians across 4 practices caring for 26,000 or so patients that this impacts. We do see an overall trend quarter over quarter. The literature shows us that we can estimate an annual savings of over $1,000 annually for every patient whose depression screen leads to creation and implementation of a care plan. We estimate a rate of 9% positive screens on all the screens done. So just because you screen somebody doesn't mean that you're saving dollars in healthcare. But if you screen someone, identify that they're having issues, and get them help, you can improve their clinical quality to the point and their overall health to the point that you can save a lot of money for that patient and for the overall health system. So here we have the practices. There are only 4 practices participating, and these are them, and how they're doing on our screening. The key interventions to produce results. I think the first thing is just familiarizing yourself with and understanding the PHQ 2 and 9 questionnaires. These are very simple questionnaires, readily available in the public domain and in the literature that you can use to assess whether your patient is showing signs of depression. If we incorporate those into our nursing assessments, it makes it easy on an annualized basis to make sure that we're asking those questions and getting that information. Another way to do it is to create a short, easy-to-use questionnaire for patients using those questions, but in their native language. We saw a huge improvement in Eastern Shore Rural Health in doing this. They have questionnaires that are both in Haitian Creole and one in Spanish for their population. And that really helped to get good information and start a conversation with the patient about the questions. Again, if you have a population health tool, or if your EHR will allow you to incorporate custom flags, you can flag when patients are due for these. That can pop up on your schedule or your huddle report every day. It can also be used to send reminders to people that they need to come in for a visit. You do need to create a solid list of community resources for your patients. And we do understand that in some communities that can be a challenge. And we've even talked to practices where, it's almost like we're afraid to start this process because what if we find a lot of people who need support and we don't have the resources to offer them? That is a valid concern, but it's not something that we want to ignore, and we have to be creative around. So first, do create that solid list of resources you do have available in your community. But secondly, we can help you to consider remote or collaborative behavioral health services. We can actually help to match you up with providers who are trained in this model of remote collaborative services, where they don't need to be at your site, but they would work with you remotely using telemedicine, basically, in order to address the needs of your patients. So the next one is LVSD beta blockers. We have 25 clinicians across 2 practices caring for a total of 3,900 patients on this measure. We use NQF 083 for this measure, and we've been able to estimate savings of $792 annually for every patient who's appropriately paced on and monitored on this therapy. This measure can be a challenge to monitor for some EHRs, and that's why we only have a couple of practices providing us with data on it. But I would encourage you, if this is something that you see regularly, if this is a patient population who you regularly see, beta blocker use is considered to be a high priority measure and one that could be very successful. If you can get your EHR to track it, we would be really interested in seeing how you're doing with the measure and then helping you if you think that you need to improve on your performance. Some of the key interventions that we use to improve performance on this measure are, again, making sure that everybody's aware what needs to be documented. And it isn't necessarily just the doctors. It could be part of the medication reconciliation process. It could be other items that need to be accurately entered in order for your EHR to accurately capture your performance. Definitely team-based care, engaging your medical assistants in the interview process to collect more complete and accurate data specifically on med reconciliation. And then using pre-visit prep to identify gaps and needs in these patients. It's always better if some pre-visit prep is done and we identify where we have gaps or problems prior to the patient getting there than it is to wait until they get there and sort of start from scratch with an empty slate and not really know what you need to talk with that patient about. So we have found that the use of pre-visit prep has been very helpful, not only with this measure, but with other measures to make sure we're focusing the limited time we have in our patient care visits to focus on the most important things. And that takes us to medication reconciliation. Now, this is the one we get the most data on because almost everybody can provide this measure to us. It's a standard measure. It has been for a while. It was part of meaningful use. So lots of people were able to collect it and report it. 146 clinicians across 52 practices caring for 87,000 patients provide us with data on this measure. We have seen a steady improvement in the measure. The downside of this measure, it is a high priority measure for MIPS, but it's also basically topped out. You have to score 100% to get a full 10 points if you're using this measure for MIPS. It's important to remember that effective med reconciliation will support many other outcome measures, and that's why it's considered a high priority measure. And when we say effective, we really mean effective. It's really not just about checking off a box. We understand that in many EHRs, you have to check off a box in order for this to count, but that's not really the process. The process that we want to go through is to truly look at the meds, have a conversation, have the patients bring their meds in so we can match them up, and make sure that we're really working off the most accurate information. We do have several practices that are at 100% on this, and so we wanted to put that up, and we wanted to talk just a little about key interventions. Again, make sure you know how your EHR knows that reconciliation is done, because this measure can have two problems. You could be checking off the box but not doing the reconciliation, or you could be doing the reconciliation and not checking off the box, and neither of those are very good. So we want to make sure that you're doing both. You're actually physically going through the process of reconciling the meds, and you're checking off the box that needs checked off to get credit for it. It's really important that we assign accountability to a specific team member to conduct this review and ensure that they're well-trained and also have the clinician review it. So it's a nice process to have maybe the medical assistant do the initial reconciliation, but then have the physician review that with the patient. And of course, we don't ask the question all over again. We don't want the medical assistant to say, okay, what drugs are you taking at home? And go through maybe their brown bag, which is the next step. And then also have the doctor or nurse practitioner, whoever the clinician is that's going to be doing the visit, ask the question as if they can't see the results. We really want to ask the question in regards, in a way to say, I see here that you are on, and go through those drugs with the patient and make sure that they understand what each of them are for. Another recommendation, brown bag med review. Bay Health Physician Alliance has done a great initiative around this, and there's information we can share with you on this, but basically it is what it sounds like. Ask the patients to put their drugs in their brown bag and bring it in, and then we want to actually look at their bottles and compare that against our med list to make sure that we're really getting what we're really seeing the accurate picture of what they're taking. And then finally, utilize your patient portal or any pre-visit questionnaires that you have to gather this information prior to the visit. If you do that and you combine it with pre-visit prep, again, you're not starting from scratch when the patient walks in. You're starting with, okay, I see here that you put in your pre-visit questionnaire that you're taking these 5 meds. What happened to your Crestor? Because you don't have that on your list anymore, but I have that in your record as if we had been ordering it for you. So you would find out if they're not taking something that we had previously ordered, or maybe something has changed. Okay, so that was a pretty quick overview of what the core measures, what we call our core quality measures, and how we're doing on them. And we're showing improvement on almost all of them, but what we want to do is be able to scale this up and get more data from more practices focusing on these measures when it is appropriate for your practice. We don't want people just trying to collect and provide data on things that they're not really able to impact. So, Valencia, could you launch the next polling question?
Certainly. And that reads, looking at the PTN core measures, A, I think I can contribute data on additional measures. B, I think I am contributing all data measures I can. And C, I want to learn more on how to improve my performance. So we're hoping for at least 75% participation. Right now, Cindy, we're at 50%.
Okay, let her go for a few minutes. Well, not minutes, seconds, technically.
We're at 58%.
Okay, guys, come on, let's give us a couple more. I'd like to be close to 70. 75 would be great.
Looks like we're holding still at 58%, Cindy.
Okay, go ahead.
Okay, great. We have 14% that say, I think I can contribute data on additional measures. 29%, I think I am contributing on data measures I can. And 57%, I want to learn more on improving my performance.
Great. Well, we want to teach you more about improving your performance. So that's a great mix. And I'm really happy that there are some of you who feel that there are some other measures you can contribute on. So we will make sure to follow up with each of you with that information, because we again want to be as helpful as we can, so you can be impacting your patient population, which of course in turn impacts the overall medical neighborhood represented by our PTN. So a next measure. This is hospitalization. So when we look at, and what we're looking at for hospitalizations is 30-day readmission. We look at that because it is a measure we can get data on from the health information exchanges, be that CRISP in Maryland or DIN in Delaware. It's important that we be able to get that data from a population perspective, because it's next to impossible for each of you individually to monitor what your readmission rate is on your patient. And so recognizing that, we've had to leverage the data that we can get. So right now, the data that we're showing you only represents, first of all, Maryland, and it only represents basically 3 groups of practices. So it's data from 3 hospitals: Peninsula Regional, Anne Arundel Medical Center, and Meredith Hospital. We have those 3 hospitals because in Maryland, those are the 3 hospitals where most of our practices are on staff, if you will. So here's how we do this one. We have 560 clinicians across 79 practices caring for about 1.17 million patients. This cohort will expand because, again, it's just Maryland right now and only these 3 hospitals. But in 2018, we're going to add a lot more practices and patients because we're going to be able to get similar data for Delaware and all our Delaware hospitals, and we're going to be able to get similar data for other Maryland hospitals where we are engaging some additional physician practices. So the way we do this is we look at the overall 30-day hospital readmission rates for these hospitals. We do a calculation of patient caseload or panel, if you will, size for our practices that practice there, and we figure out what percentage of the hospital's patients are actually followed within our practices. And then we look at the overall performance of the hospital, and we just take credit for our percentage share of that improvement. We feel that we can do this because of how we're working with the hospitals and the practices. First of all, we have collaboration with our hospital ACOs and with hospitalists to coordinate care using clinically integrated network models. So even if our PTN, all our PTN practices are not in the ACOs or part of the primary care practices that impact these hospitals the most, they are the specialists that are supporting those practices. And we work closely with the ACOs and the hospitals to make sure that, when they're working on things, that we can take that message out to our specialty practices and make sure they're collaborating with the hospital. The other thing is implementation of risk stratification and care coordinated patients with high clinical or social risk of readmission. So we want to be looking at working with the hospitals and with practices to look at who are our high-risk patients. Can we refer those patients to care management resources? I can tell you that at Anne Arundel, that's exactly what they've implemented, something called one-call care coordination, where not only the PCPs but the specialists can make one call to care coordination, and the care coordinators will figure out who should be following this patient. Is it them? Is it a care manager from a PCP's practice? Is it somebody from maybe Care First, where they have care managers taking care of high-risk patients? And I think most importantly, the thing that all of our practices can do is use the event notification system through the state HIE to ensure post-discharge follow-up. We know that if patients get prompt follow-up post-discharge, they are less likely to readmit to the hospital. And so if the one thing that all of our practices do is use event notification to understand when patients that they know are high risk have been admitted to the hospital, that they can follow up with them and get them in quickly for a post-discharge visit, we know that that will improve our 30-day readmission rate. As far as tests and procedures go, this is probably the aim that we have the least participation in, and probably the one that creates the most challenge for us. We have 185 clinicians across only 9 practices, caring for about 279,500 patients. We are basically working with a few practices on individual projects, 2 on colonoscopies, 1 on ankle MRIs. And then we have initiatives going on in the emergency departments at both Bay Health and PRMC to reduce unnecessary imaging for different diagnoses. We started with low back pain at Bay Health and PEs at PRMC, but we're expanding in the next quarter to 1 additional test at each site. We also are working on expanding our colonoscopy performance in this area by having an affinity group for all of our gastro practices that if you're a gastro practice, you've been asked to participate in. And what we'd like to do is take some of the lessons that we've learned and best practices from the 2 practices that we did work with and see what fits for your practice. This is particularly timely because with cost measures being added to MIPS this year, and next year likely those cost measures being specific to episode-based care, and this being one of the focus areas that CMS has identified, we think that it's going to be important to make sure we are truly using evidence-based care in the delivery of our colonoscopy services. So if you look at the key interventions, using individual PDSA projects in a specialty practice, any of you can go out there and look at choosing wisely, identify things that maybe you've been concerned about that you're ordering too much. We don't want you to focus on the cost savings there. What we're really trying to focus on is patient safety and exposure. We don't want to expose people to radiation on a lot of these tests if we don't need to. We don't want to put people under a general anesthetic for a procedure if they don't need it yet. So we want to make sure that we're thinking about patient safety and decreasing risk and radiation exposure when we look at the procedures we might want to try to impact our utilization of. Implementation of pre-procedure screening by team members is really important. Teaching everybody what the appropriateness criteria are for these different tests. And if you can hardwire it into your EHR, even better, to kind of ask you the question, are you sure this is what you want to do? Does this person meet this criteria? Elimination of unnecessary office visits prior to and after procedures is something we have found that can save significant dollars and improve patient satisfaction, because if they only have to go once to get the test done and they don't have to make that 3 visits, less time they have to take off of work, and that's a more efficient process. And then we do have the ability through the American College of Emergency Physicians and the American College of Radiology to work with practices on collaboratives with some set criteria, some set processes that you can follow that will help target some very specific tests. So your practice advisor can help you with those. And so finally, our cost savings slide. Granted, we are trying to focus on getting our patients better, but we also know that the healthier our patients are, the more we save, both for our patients and for the overall medical community in general. We have over 1,000 clinicians from 202 practices caring for 2.2 million patients who provide us with measured data of some kind or another that contributes to the dollar savings that you see here. We're well on our way, but we can't stop now. We have to absolutely maintain gains and make sustainable change. So all of those MIPS measures that you're working on, all of our core measures that you're working on, if you have made gains, we want to make sure that you are comfortable that they're sustainable, that you have processes in place that you can keep up so that we don't backslide. We want to add new practices to our cost-saving roles. So those 14% of you who said you thought you could provide more data, we'll definitely be talking to you because we'd love to add more practices to our data collection so that we can actually quantify that savings. And we want to expand all quality and utilization measures to more practices. We have done extensive work in the past 2 years that we've been together as a PTN, practices and practice advisors, to get internal operations in order. We've really focused very internally with all of you, helping you to get prepared to launch into MIPS. And now we're into MIPS, so we're really at a position where we need to keep doing what we were doing, but what's the next iteration? What's the next step? And that next step is to play a larger role in the overall medical neighborhood. So, summary, we're showing gains on our core measures. Our gains are due to many small individual practice projects that are impacting care on many individual patients. While year 1 and year 2, we've collected, aggregated, and analyzed our data and implemented best practice, we're ready for MIPS. In year 3 and 4, we have to continue implementation of best practice and add collaboration in our medical neighborhoods to improve the overall population health and reduce costs. Sustaining our improvements is important and necessary for continued success. So that's of all that I've talked about today, those are 5 important bullet takeaways. And this is our path forward. In years 1 and 2, we were really focused on improving individual patient health and improving the health of the practice population. It's been very internal. Understanding your individual patients and then how does their information aggregate up for your practice and represent the overall picture of your practice. In years 3 and 4, we need to be concerned also about improving the health of our local population, our own medical neighborhood, reducing that readmission rate, working with either the PCPs or specialists in our neighborhood and our hospitals to reduce those readmission rates and ensure optimal health for our patients, improve access for them to get follow-up visits, all of those things, use our case managers effectively. And then finally, also in year 4, that's going to lead us to improved health of the total population. So you can see this all builds. Sure, we start with the individual patient. Are we doing the right thing for them? But then how does our overall population look in our practice? How does our population add up to the overall local population? And then how does that go into the total TCPI population nationwide? So all that being said, I've talked a lot today. I have in the TCPI format, as our leader, Lieutenant Commander Butler likes to tell us, requests and offers. And that's how we move things forward. We make requests and we make offers. And these are our requests and offers for this particular initiative. Our requests are things that you can help us with. And so how can you help us? Well, first of all, you can ensure your improvements can be sustained into the future, that you have a documented process and policy, that everyone that needs to be educated has been educated, and that you have standardization within your practice. You need to continuously check your performance data. We've talked a lot in the first 2 years about creating dashboards or routine quality reports that help you to monitor in real time, or at least more frequently than once a year, how you're performing on the individual measures that you have selected to demonstrate the quality of your practice. We need you to take action when trends show gaps or regression. So we don't want to wait till the end of the year and look at the data and say, oh my God, what happened? We want to be looking at it as we go so we fix anything that's wrong as it comes up. We're asking you to critically assess your use of evidence-based guidelines. We really want you to go out and look at choosing wisely resources. And we'd like you to try to work on hardwiring those guidelines into your processes and, if possible, your EHR. Make them routine to follow the guidelines that are out there. And finally, we're asking that you identify additional PTN core measures you can contribute data on. Can you provide us with data on hemoglobin A1C, on blood pressure control, on depression screening? Is depression screening, especially that one, is that something that you haven't been doing yet? Do you need some help in figuring out how to get started on that? We can help you with that. And so start collecting data. And this is the thing about the data. It's not just, are you doing great at it now? If you're not doing great at one of these things now, but you want to be doing great at one of these things now, that's okay. Because what we're trying to measure is improvement, not necessarily performance at this period in time, but performance over time. So those are our requests. That's how you can help us in being a strong member of our PTN network. offers are the things that we're offering to you. How can we help you? Well, first of all, we can meet regularly with you. Your practice advisor wants to meet regularly with you. If you don't have a routine meeting on the calendar with your practice advisor, I like to meet with my practices at least every 2 weeks. We don't always. Sometimes we meet once a month, but we meet regularly. And so what we want to offer you that service, to meet regularly with you, because we are here to answer your questions and help you track down different processes, initiatives, best practices that you can implement in your practice. We can offer you condition or EHR-focused affinity groups. We want to bring you together with your peers who are working on similar issues for informal sharing and support. We are already doing this in 2 areas. We have a EHR affinity group based on one of the EHRs that we had quite a few practices using. They have met numerous times. They share best practice with each other. They help each other problem solve how to better use their EHR. So we would like to do more of those. We would like to do some affinity groups around these core measures. We already have launched an affinity group, the gastro affinity group, and we're working on looking at colonoscopies and making sure that we're all using best practice and following evidence-based guidelines in the use of colonoscopies. But we would like to do the same thing around diabetes, hypertension, depression screening. And usually these groups are small, and again, they're peer-based. We're there to facilitate the conversation amongst practices. And finally, the monthly webinars. We do really encourage you to attend these sessions as they're announced to focus your activities and get new ideas for improvement. Know that if you can't attend a webinar, we'd love you to do it real time, but if you can't attend, we do save all of these to YouTube. And so you can just go out to YouTube, search Health Visions Delmarva PTN, and you can see every webinar that we've ever done. So if there's a topic that we've done before that you want to watch, it's out there. If we do something in the future you're unable to attend, you would be able to see that. So all that being said, Valencia, can you launch my final polling question?
Certainly. And that asks, I would be interested in participating in an affinity group on, and multiple answers may apply for this one, improving diabetes management, improving blood pressure control, implementing depression screening, improving medication reconciliation, reducing 30-day readmissions for my patients. We have about 20% that's voted thus far.
Okay.
We're about at 42%, with half a minute left
Okay.
into this poll.
Definitely want to get a few more. Vote early and often. You can pick more than one.
Looks like we're holding still at 50%, Cindy, with 33% looking to improve diabetes management, 83% improve blood pressure control, and 17% reducing 30-day readmissions for my patients.
Okay. Well, that is actually helpful to us, guys. Although I know we don't have as much participation as I would hope, that's helpful to us to figure out where we want to put our efforts and resources. We can't do a million affinity groups, can't have everything going at once, but this helps us to prioritize, so I appreciate that. So that wraps up my presentation part of the session. I do have up on the screen the last slide, which is our contact information. I wanted to throw out there, we didn't create a slide for it, but I wanted to let you know that we are working to put together a session on combating clinician burnout and improving joy in work in May. That would actually be a session that would be held at multiple sites on site, sort of simulcast. Our speakers would be at one site. They would be televised to other sites so that it would be more of a workshop setting. We're aiming for a May date, and it would probably be from noon for about an hour and a half. So more to come on that, but I want you to be thinking about that, because I think that is a really important topic for us to be addressing. We absolutely understand the enormous number of demands made on your time. And so anything we can do to try to figure out ways to help mitigate the stress and burnout of patient care and patient care services, we're going to try to do that for you guys this year. So Valencia, are there any questions from the chat box or hands raised?
Yes, Cindy, we do have one question. The question is, how do you know if the BP cuffs are calibrated?
Okay. I cannot get into the technical answer of that right here, but I will have someone get back to you and let you know. Now, if you're I will tell you this. The only way that I know of to really look at a home BP cuff, so if that's what we're thinking about, as opposed to your office equipment, is you take someone's blood pressure, you have them bring their cuff in. You take their blood pressure with your device. You take their blood pressure with their device. You're basically looking to see, do they match up? I've had this done with my own provider. And so what she normally does is she does it twice. So at the beginning of the visit, she takes my blood pressure with theirs. Then she takes it with my machine. She writes both of those readings down, sees how far apart they are from each other. At the end of the visit, we repeat it. So what we're looking to see at least is for some consistency. And for the most part, each time, what they've been able to tell me is, okay, you know, the diastolic seems to be reading well, but your systolic seems to be off by 5 points. So always be wary of that systolic measure. It's probably within 5 points of where you think it should be, but it might not be exact. I will, though, get a resource out to the person who asked that question to make sure that you know how the best practice is recommended for doing that.
Okay,
good question.
Great. Thank you.
Good nuts and bolts question. I love nuts and bolts questions.
That was the only question that I see here for today.
Okay. Well, it is 12:59, so we came right up to the hour. I appreciate everybody's participation today. We will take a look at all the answers here, and we're going to get back to people on the projects that they felt that they would want to work on as far as affinity groups go. And if you need some support with your measures, we're going to get back to you on those too. So thanks again. Everybody have a wonderful rest of the week and a wonderful weekend. So long.
Thank you.